non-serum electrolytes. Okay, so yeah, as we all know that as we all know that what is an electrolytes. Okay, so basically blood and other fluids in the body have many cations, right? So cations in the sense is nothing but positive ions. So for example, sodium, potassium, calcium, etc. And we are having many anions too, which includes phosphate, chloride, bicarbonate, etc. And then these electrolytes are having many clinical importance. So out of these electrolytes, sodium, potassium, and chloride are most important things, and these three things will be routinely it will be routinely estimating these things in the plasma or serum in our clinical laboratory. Okay, so this is an important thing because most patients admitted in hospitals for treatment for various ailments. Okay, so obviously we will be taking that intravenous blood samples, and then we will be seeing that electrolytes, the level of electrolytes which is present in the sample. Okay, so and then uh, out of these electrolytes we will be majorly seeing three electrolytes basically. So number one is nothing but sodium, number two potassium, and then number three chloride. Okay, so and then these electrolytes are very crucial in the evolution and management of acid base disorders. Yeah. So this is the outline of this electrolyte analysis. Okay, so what is an electrolyte, uh, what we are doing with these things. Okay, and then today we will be focusing more on these electrolytes. Okay, so when we are lack of electrolytes, you just need to replenish these electrolytes. Okay, yeah. So synopsis for this topics, which includes first one is history. Okay, so and then what is the definition behind this, and the third one is nothing but so this electrolyte analysis. So the electrolyte analysis is an instrument which is used to analyze the electrolytes. Okay, so this is a topic which they had been given in a journal. It's nothing but electrolyte analyzer. Okay, so and then fourth one is nothing but what are the components of electrolyte analyzer, and fifth one is nothing but clinical complications and various advantages of electrolyte analyzer, and finally we will be seeing that electrolyte imbalance. So electrolyte imbalance, it plays a vital role in case of clinical conditions. Okay, and first we will have a look into that history. So in history, the first credit will goes to the scientist named as Kremer. Okay, he is a person. Sorry, he was a person who had described based upon the pH in during 1906, and he had put some. I mean, he had published with the words about this electrolytes in 1906 paper itself. In 1949, George Perley, the scientist, who published an article on the relationship of glass composition to pH function. Okay, and the third one is the most important one. So this commercial development of ISE. Okay, so ISE. So ISE. So once you hear the name, that's why in this initial stage we had given this topic as we had given the method as ISE. So make a note of it. ISE is nothing but ion selective electro. This is a method. By this method only, we are estimating the electrolytes by using that. I will be repeating. So this method, by using ISE method only, we are estimating the electrolytes levels in the electrolytes levels in the given sample. Okay, so basically, like in the commercial development of ISE began, the two scientists that came up with the idea. The number one is nothing but John Reisman. So he's an engineer. So he thought of developing the blood gas analyzer, and then he had teamed up with the Dr. James Rose. So James Rose plus John Reisman. James Rose plus John Reisman. They are the electrochemists. I mean, they are this James Rose is an electrochemist from MIT. They together. So James Rose plus John Reisman. They together uh, formed an Orient Research. Okay, so in the midst of 1960s, they newly formed the Orient Research by introducing calcium electrodes. Okay, so calcium electrodes. So for using the blood gas analysis, majorly they had focused on the blood gas analysis, and then later they come to the level of estimating the serum electrolytes. Okay, so they had used numerous probes for analysis in the samples over there. Okay, this is a history behind this. Okay, let us come to the discussion about definition. What is the definition for this? I mean, this electrolyte analyzer. So definition is nothing but a very simple one. So an ion selective electrode is nothing but ISE. Okay, is it will be acting as a transducer. A transducer is otherwise known as an electrochemical sensor. Okay, transducer or an electrochemical sensor. So this one will convert the activity of specific ion dissolved in a solution into a electrical potential. Okay, and then we'll move on to the next slide. So what happens? So this ion selective electrode are used in clinical chemistry. For what purpose? For measuring the ionic concentration of various analytes. So the analytes are nothing but, so which include sodium, potassium, calcium, and lithium. Okay. So what is the principle behind this? Let we will discuss about the principle. It is basically works on the principle of potentiometry. So potentiometry is nothing but direct method like pH meter. So if you want to see the pH of the particular solution directly, we will put into the machine that will directly will be observed by the probe, and then that will be giving the result like that. Like the potentiometry techniques will be used. I mean, potentiometry is a principle behind this. Okay, and then they will be using an ion selective electrode. An ion selective electrode. Okay, so what is the use of this ion selective electrode? So this ion selective electrode will generate a difference in electrical potential between itself and a reference electrode. Okay, so the output potential. So the second point is nothing but an ion selective electrode will generate a difference in an electrical potential. So that's an important principle behind this. So this is an ion selective electrode. What it does? So what is the use of this ion selective electrode? This one will generate a difference in electrical potential between which one? Between itself and a reference electrode. Okay, so this ion selective electrode will generate a difference in, there is a, I mean, there will be a difference in electrical potential between what and between which one and which one, between this electrode and a reference electrode. Okay, this is a ion selective electrodes. This is the use of ion selective electrode. And then third point, so the output potential. So what will be the output potential? So the output potential is proportional to the amount of the concentration. If for example, if you are giving any sample solution, if it is absorbed by the ion selective electrode, so and then there will be a difference will be produced, and then that will be, I mean, that will be giving that using the reference electrode, your values will be given like that. The output potential, the amount of output what you are getting is directly proportional to the amount of the concentration of the selected ion in the solution. If you want to measure that chloride ions, you will be having separate one. Okay, and then if you want to measure that potassium ions, that will be like a separate one. Okay, separate electrodes will be there. And then compounds. So what are the various components present in this uh, electrolyte machine? So number one is nothing but a reference electrode. So what is a reference electrode? And number two is nothing but sample chamber, and then ion selective membrane. These three things plays a vital role in case of that serum electrolytes machine. And then fourth one, the inner electrolyte chamber. So what is the use of that inner electrolyte chamber? And fifth one is nothing but voltage source. And the sixth one, peristaltic pump. Okay, so we will discuss one by one. Okay, so what is a reference electrode? So the reference electrode is nothing but an electrode which one will be having a constant voltage. So it will be supplying a constant voltage. That's why it will be called as a reference electrode. So like a known substance, I mean like a known value. So this reference electrode will be supplying the constant voltage. That's why it's called as reference electrode. So what it made up of? It is made up of Ag or AgCl2. And second one is nothing but sample chamber. So what is a sample chamber? What it contains? It contains a specimen to be measured. For example, if you want to calculate that serum of some X sample. Okay, so if you are giving that egg sample serum, right, so that will be placed only in the sample chamber. Okay, so that contains a specimen to be measured. This is nothing but this is the use of sample chamber. And third one is nothing but ion selective membrane. So what is the use of this ion selective membrane? So there are, I mean, this membrane will be contains different electrodes, so which includes, so for example, if you want to calculate if you want to calculate this value of sodium, potassium, I mean chloride, and then other things, right? So this selective, for example, this ion selective membrane is the only one which will be selectively, I mean each one of the ion will be having a separate electrodes. For example, potassium will be having separate electrode, and then I mean sodium will be having a separate electrode. Okay, so each and every molecule will be having a separate electrode. Okay, so whose constructions are made up of operation of differ considerably. Okay, so and then fourth one is nothing but inner electrolyte chamber. What it has, what is the use of this? It contains electrolytes. Okay, so and then voltage source. The voltage source is meant for to measure the voltage electrode potential. A constant voltage source is needed for a reference potential. Okay, the voltage should have to be supplied in a constant. Okay, then only that reference potential will be function. Okay, and then sixth point is nothing but peristaltic pump. What is a peristaltic pump? So as we all know that peristalsis movement is nothing but transport. So transport of all samples will be happening by this one. So transport of all samples and operation fluids inside this instrument only. That's why they are given the name peristaltic pump. Okay, and then snapback. So what is snapback? This is nothing but ISE. Okay, so this ISE, this ion selective electrode snapback is constructed. So what is happening over there to ensure that waste cannot spill out? So if the absorption, if that sample had been intaken by that machine, so this snapback will control these things, so the sample should not spill out. Okay, from the package. This is the use of the snapback. Okay, so and then printer. So what is the use of this printer? So this is nothing but they we will be using only thermal print. Okay, so after the values had been noted, that values will be printed and calibrated. Okay, so the electrode voltages and the amount of liquid remaining the snapback will be, I mean, snapback will be maintained with the help of printer over there. The information will be shown with the information will be seen with the help of printer only. And then now we'll move on to that working or sample processing, how this machine is functioning and how this machine is working. So first we'll be taking the blood specimen. So blood specimen in the sense we can able to collect serum sample. So and then that will be collected and presented through the small probe, and be like substantially presenting in the machine over there. The sample is taken through the probe, and then what happens? So one need like a substance like that will be going for dipping that tubes. After the dipping, right, the samples will be getting entered into the probe. After getting entering into the probe, that sample will be transferred to the peristaltic pump. So peristaltic pump. So the peristaltic pump that will be loading the chamber with the sample. Example, first what happens, we will be taking the blood sample. After taking the blood sample, we will be going for centrifugation and everything. After that, that will be kept in the machine. So after keeping in the machine, right, what happens? The blood sample, if you're keeping the blood sample in the machine, the probe will be coming. The probe will be coming, and suddenly that will be going for insertion. So after the insertion of the needle, after the insertion of the needle probe into the sample, so the sample will be absorbed by the probe. The sample will be absorbed by the probe, and then that sample then suddenly enters into the peristaltic pump with the help of the probe. So after entering into the peristaltic pump, that will load the chamber. Okay, the sample will be, now the chamber will be fully loaded with the sample. So second step, what happens if the sample get loaded with the peristaltic pump? Okay, peristaltic pump and the chamber. The sample then resides in the chamber for long time. Okay, so up to what time? Up to allow the thermal equilibrium. So that will be going for heat equilibrium, thermal equilibrium for the completion of measurements of all the electrolytes. Okay, what happens to the third step? So there will be the concentrations of iron. So since we had given that tubes, the sample, so it had been absorbed by the probe, and then that will be going for thermal equilibrium. So and then concentration of ions will be calculated. So how the concentration of ions had been calculated? Okay, this is calculated by from the measured potential. So measured potential, the potential which measured potential difference between two electrodes. So this is a principle behind the principle what we had seen at the earliest. Okay, so there will be the development of two potential difference between, two electrodes, and then that electrode potential will be showing as concentration of ions. So this is the final thing. So the complexity of the ion selective electrode, so which had been designed, so it depends on the membrane, so the barrier composition which is there to determine its ion selectivity. Okay, and that's what, after that, that had been completed. So now we'll move on to electrodes. So the glass electrode, what is a glass electrode and polymer membrane? So this glass electrode and polymer membrane are two types. Okay, so these electrodes are basically used in clinical chemistry application. Now we will see we will go deeper into the glass electrode. What is a glass electrode? So what is the use of this? So the glass electrode is nothing but the most common ISE, ion selective electrode, what will be using, what we are using in the machines. The most common ion selective electrode is the glass one. So the that had been comprised with that body pH combination electrode. They will be used to measure pH, and then we can able to see sodium and internal transducer for PCO2 sensor. So it will be having one sensor. That sensor is nothing but PCO2 sensor. And then next point, the glass electrode membrane has formulated from the melted silicon, because already we know the thing, right? So glass had been made up of silica only. From the sand only we will be making the glass. Okay, so this glass electrode membranes are formulated from melts of silicon. Okay, and then that had been mixed with the combination of aluminum oxide, which mixed with alkaline earth metal cations. Then next point. So next one is nothing but a liquid ion exchanger. So what is a liquid ion exchanger? So they are used for monitoring pH. So they are used for monitoring pH and measuring the electrolytes. So we'll be measuring all the electrolytes by with this one. So this liquid ion exchanger is nothing but polymer membrane electrode. This electrode is used for monitoring the pH and for measuring electrolytes, which includes all the things, which includes potassium, sodium, chloride, calcium, lithium, and magnesium and carbonate. Okay, so the electrode potential of solution is measured by their effect on the ion exchange material. This is a previous principle what we had seen. So the electrode potential of a solution is measured by their effect on ion exchange material. And then they are predominant class of electrodes. This a liquid ion exchanger electrodes is a predominant class of electrodes which is used in modern clinical chemistry. Yeah. So now, what is a clinical application and advantages? So the most important critical care analytes are gas, electrolytes, and glucose. They are directly in serum. We'll be taking that. We'll be measuring with directly in the serum. Okay, without need for sample pretreatment or dilution. Okay, and then what are the samples we'll be intaking? So to see this, okay, we can able to take. I mean, we can estimate with the help of a whole blood sample. We can estimate the serum sample. We can estimate the plasma dialysis solutions which containing acetate and bicarbonate, and then we can able to see the urine, and then we can able to calculate the QC material also. The measurement is not affected by the sample turbidity, or which includes red cells getting contaminated over there, and any lipid contamination. And so it will show only the analyte. What analyte is present in the water phase of the plasma is measured. This is the most important thing, most important clinical advantage. So this is a schematic diagram of ion selective electrode. So just look into it. This is the journal. So we'll just have a look into it. So first, high input of impedance voltmeter will be there. So which is used to for measuring that values over there. And then just listen to this. So AgCl will be there, and then potassium chloride will be there, ion selective membrane, and then inner electrode membrane. So which comprise of Ag or AgCl. Okay, this is the schematic diagram which had been given over there. So this is that electrolyte analyzer. Okay, so and then the most important thing is nothing but electrolyte imbalance. Up to now we had seen, so what is an electrolyte, so what is the principle behind this electrolyte analysis, so what is an electrode, what are the types of electrode. Okay, so how we are what is the principle, I mean, what is the methodology behind this electrolyte analyzer machine. So like that we had seen, and then what is the advantage of the electrolytic machine, and then what is that potential difference between the two electrodes, like that we had seen. Now we're gonna see about electrolyte imbalance. This is the most important thing as for the clinical complications is concerned. Okay, so what is an electrolyte imbalance? So as we all know, so our body has I mean composition of these are the composition of electrolytes by our body components. As we all know, we had two components, so ECF and ICF. Okay, so extracellular fluid and intracellular fluid. So okay, so the electrolytes. So electrolytes, what is the amount of electrolytes which is present in ECF as well as in ICF? So sodium will be present like 135 to 150 milliequivalents. Okay, in case of ECF. And then in case of ICF, that will be about 10 to 18. And then in case of potassium, so potassium will be about 3.5 to 5 milliequivalents. And then in ICF, that will be about 120 to 145. And then calcium will be about 8.5 to 10.5 milligrams per deciliter. But in case of magnesium, just have a look into this only. So look into this, I mean electrolytes only. And then magnesium will be about 1.5 to 2.4 milliequivalents. And then in case of ICM, that will be about 30 to 50. And chloride will be about 95 to 108 in case of ECF. What about in case of ICF? That will be about 2 to 6 only. But phosphate level seems to be like 2.5 to 4.5 milligrams per deciliter in case of ECF, and 25 to 60 in case of ICF. Okay, and then what is the composition of GA secretions? So what are the composition, I mean, what are the composition of GA secretion? And then we can able to see so much of electrolytes in case of GA secretions, so which includes, so in saliva we can able to see 10 sodium levels, 10 milliequivalents of sodium, and then 25 milliequivalents of potassium, and 10 milliequivalents of chloride, and 30 milliequivalents of bicarbonate. In stomach we can able to see 60 to 90 milliequivalents of sodium, and then potassium will be about 10 to 30 milliequivalents, and then chloride will be about 100 to 130. In case of duodenum, that will be about 140 milliequivalents, and sodium will be about 5 milliequivalents, and chloride will be about 100. So in case of mixed gastric aspiration, we can able to see a 120 milliequivalents, and then potassium will be about only 10 and chloride seems to be like 100. You can able to see bicarbonate only in two things over there, in saliva and ileum. And then at last we can able to see pancreas and bile also we can see the bicarbonate. But we look into the colon next. Okay, in the colon the sodium level will be about 60 and potassium will be like 30 and chloride will be about 40. In case of ileum, right, we came across 140 milliequivalents of sodium and 5 milliequivalents of potassium and 100 milliequivalents of chloride and 30 milliequivalents of bicarbonate. Okay, and then in case of stool, in stool we can able to see 35 milligrams of sodium and potassium seems to be like 3 to 12 and chloride seems to be like 20. And then in case of pancreas, so that same amount just like the duodenum, so like 140 milliequivalents of sodium and potassium seems to be like 5 milliequivalents, and then chloride will be about 75 and bicarbonate seems to be more in case of pancreas, about 115. So in case of bile you can able to see 140 milliequivalents international units, and then for potassium will be about 5 and chloride will be about 100 and bicarbonate will be about 35. Okay, so now we will discuss about potassium. What is potassium? If it is getting increased, what happens? What are the conditions related with this potassium levels? So potassium. So as we all know that potassium is a primary intracellular ion. So it provides a vital roles in regulates in the regulation of cell excitability. So what is the RDA? So the RDA will be about 4,700 milligrams. That includes zero point 0.6 to zero point 0.8 milliequivalents per kg per day. So this one provides a vital roles in the regulation of renin, angiotensin, aldosterone axis. Okay, and then fifth one is nothing but it has a relation to acid base balance, because acid base balance we have to maintain our pH between 7.35 to 7.45. If the pH had been increased, our acid base disorder, we can able to get acid base disorder, which includes acidosis as well as alkalosis. Okay, so if the potassium decreases by zero point 0.3 milliequivalents per zero point 0.3 milliequivalents, so what happens? So there will be the increase of zero point 0.1 increase in the pH. If the potassium decreases, the pH will increases. This is the most important thing. If the potassium getting decreases, so what happens? pH will be keep on increasing. For example, in the ratio, if zero point 0.3 milliequivalents of potassium getting decreased, so what happens? So 0.31 level of pH will be increased. Okay, for every zero point 0.3 milliequivalents of potassium decreased levels. So, okay, so if potassium decreases, pH will increases. Okay, that will leads to alkalosis. Yeah, so it will lead to, if the based on the potassium level, that will be leading to two condition. One is nothing but hyperkalemia and another is nothing but hypokalemia. So hyperkalemia, so it is due to the increased intake, and then so it is due to increased secretion of potassium, and then it is due to impaired excretion. So in what are the conditions you'll be getting hypokalemia, which includes number one, inadequate intake and excessive excretion, and then GI losses and misc. Okay, so and then so this is the most important thing. So if the potassium getting decreased, so what happens? So number one is nothing but most important thing, that will be leading to alkalosis. Okay, so mnemonics acid vault. Okay, so first one is nothing but alkalosis. Second thing is nothing but the persons will be more prone to shallow respirations, and then third thing is nothing but irritability, and then the persons will be having confusions. So okay, and then fifth one, they'll be having weakness, and then they'll be having arrhythmia, and they'll be more lethargy, and then the pulse seems to be like some thready, and then intestinal motility will be decreased. So by using this, so mnemonics, alkalosis, shallow respirations, irritability, confusions, weakness, arrhythmia, lethargy, thready pulse, and intestinal motility, they will call it as asequality, right? And hyperkalemia. So during hyperkalemia, what happens if the potassium level gets increases? So number one, the most important thing, the muscle will be going for cramps. So and then muscle will be going for weakness, and then that muscle will be going for paralysis. So muscle will be going for cramps, and then we'll be getting weakness, and then we will be prone to paralysis, and then the persons will be going for drowsiness, and then bp will be reduced. Bp will be reduced in case of hyperkalemia. And then EKG changes. Okay, so it's nothing but, so it will be like ECG. So ECG changes. So it's nothing but ECG. Okay, so and then a dysarrhythmia will be happening, and then abdominal cramping will be there. The person will be prone to diarrhea, and then person will be more prone to oliguria. So and then, so these are another mnemonics. During hyperkalemia signs and symptoms, we will be having the mnemonics. We'll be using the mnemonics murder. So murder in the sense that includes the muscle. The person will be having muscle cramp. So urine abnormalities. So respiratory distress will be there. Decreased cardiac contractility, and then in that ECG, right, there will be kg changes will be there, and then reflexes will be there. Okay, so we will discuss about that ECG pattern. So during hypokalemia, what happens to the ECG? During hyperkalemia, what happens to the ECG? Okay, so during hypokalemia, you can able to see the prominent U wave. The prominent U wave, the U, you can able to see the prominent U wave, and then you can able to see that biphasic T wave, and then there will be the depressed ST segment. Can you able to see this is ST segment? Okay, and then during hyperkalemia, what happens? So during hyperkalemia, you can able to see the tall T wave, and then there will be the prolonged QRS wave, and then PR interval seems to be long. Okay, so that's why this potassium levels plays a vital role in case of ECG. So if that ECG is getting disturbed, right? So what happens? The persons will be going for, so it denotes our heart is not functioning well, so the persons will be going for cardiac arrest. So that's why potassium levels plays a vital role in case of ECG. Okay, I mean heart function. So number one, I will repeat. So okay, so this is a ECG pattern. So in the ECG pattern of hypokalemia, you can able to see the depressed ST segment. So ST segment will be depressed, and then you can able to see the biphasic T wave, and then the U wave seems to be like somewhat prominent. And then in case of hyperkalemia, so increased level of potassium, what happens? Just compare this both the things. So during hyperkalemia, what happens? You can able to see the prolonged QRS wave. Okay, and then PR interval seems to be too much of long. And then what happens in case of T wave? T wave seems to be tall. Okay, so what is the treatment behind this hyperkalemia and hypokalemia? First, we will finish up with the hypokalemia. So okay, so the based upon the body weight, they'll be giving that potassium levels also. Okay, so it will be going with the formula zero point 0.4 into body weight into deficit. Okay, so this is the thing. This is the and then they will be seeing whether the person is having hypokalemia or acidosis or like this, like that. And then they'll be seeing that refractory cases. They'll be, by considering the TC, they'll be going for refractory cases, and then they'll be looking to it whether to give the peripheral or central line. Okay, so these are the most important things. So and then which includes, yeah, treatment of hyperkalemia. It will be most they will be stop all oral and IV infusions of potassium. So in case the potassium level have been increased, so okay, they will stabilize the heart. Okay, and then they will see the bicarbonate level, and then they will measure the short term measures, and then they will be going for permanent measure. First they will cue the first they will try to put the patient the normal thing, and then they'll be going for permanent measures. And then now we'll move on to sodium. Yeah, in case of sodium, right? So we can able to see, the sodium. So the primary is a sodium is a primary extracellular ion. So it is most important for maintenance of constant internal environments, nothing but homeostasis, and for the action potential in the body. Okay, so this sodium will control the water movement. So this sodium will control the water movement of in and out of the vascular system. So okay, so first one, this sodium plays a vital role in case of so extracellular metabolism, extracellular ion. This is a primary extracellular ion. What is the use of this? This plays a vital role in case of homeostasis and action potential in the body. And third point is nothing but it controls the water movement in and out of the vascular system. And then it will be regulated by ADH, anti-diuretic hormone. And then what is a RDA of sodium? So RDA will be like 2400 mg. Okay, so and then so 1 to 2 milli equivalents per kg per day, and then serum osmolality will be like 2 Na 2 into 2 into Na is nothing but sodium is the bond ratio plus the bond divided by 2.8 plus glucose divided by 18. So this is the osmolality, serum osmolality. Okay, so and then they will be using this blood urea nitrogen and blood urea. Okay, so they'll be going for bond ratio. Okay, and then so if that sodium level had been increased, is nothing but hyper I mean hypernatremia. Okay, if the sodium level had been decreased, nothing but hyponatremia. First we'll finish up that hyponatremia. So hyponatremia, so can able to see, so hyponatremia, it plays a vital role in case of hypotonic and hypertonic. So every 100 gram of fall in glucose level, so we can able to give, so we'll be getting 1.6 milli equivalents fall in sodium. So if that 100 gram of glucose is reduced, what happens in sodium level? 1.6 milli equivalents will be reduce in case of sodium levels. Okay, so and then so renal and extra renal, and then volume status, what is the volume of sodium over there, and then ADH and the sodium osmolality. So we will be seeing all the things. So what are the signs and symptoms of hyponatremia? So which includes the signs and symptoms of hyponatremia, which includes, okay, so they will be getting lethargy, they will be seems to be somewhat lethargy, and then they will be more prone to headache, and then they will be like having confusion. Okay, so and then they will be having seizures, and finally they will be going for coma. Okay, so and then they'll be having apprehension also. So then hyponatremia occurs when serum sodium levels are less than 135 milli equivalents per liter. So when the sodium levels are less than 135 milli equivalents per liter, they'll be going for hyponatremia. And then sodium, I mean, decrease of sodium will be if the persons are having going for dilution of excess of water. Okay, so automatically the sodium will be going for decreasing level, and then sodium will be lost also. So these are the some of the situations you will be getting that hyponatremia. Number one is nothing but when serum sodium is less than 135 milli equivalents per liter. So when sodium is reduced and sodium is decreased, that will be causing the dilution of result of excess of water. So due to that, what happens, or the sodium will be losing, increased sodium loss. These are the some of the situations. Okay, so during diuretics, during vomiting, during gastrointestinal suctioning, during diarrhea, so these are the things. And so during fluid imbalance, these are the things you'll be getting. So this in this clinical condition, you will be getting hyponatremia. So you should have to you should have to think of that, what is hyponatremia, what is the signs and symptoms, and what are the condition you'll be getting hyponatremia. And we'll be coming for the treatment. So what is the treatment for hyponatremia? How to correct that hyponatremia? So you should have to take the value, and then you should have to measure the value. After that, you should have to enter into that formula 1.6 m divided by, in case of males, right, you should have to use 1.6. In case of female, you should have to use 1. So in case of male, you should have to use zero point 0.6, and then in case of female, you should have to use zero point 0.5 into how much it is deficient into BW. Okay, so and then you will be going for hypovolemia. What is hypovolemia? So decreased level of volume of sodium in the blood, sodium over there. And then euvolemia, water restriction, and hypovolemia, in case that you'll be going for salt and water restrictions. And then in through IV saline, right, they'll be going for loop diuretics. Okay, so in case, right, sodium seems to be like in case of sodium or seems to be in case of sodium treatment and hyponatremia, you can able to get neurological symptoms. And then that in case of 3% of I mean 3%, like you'll be going for. Okay, we will discuss about all the things. I mean, I think you all will be having a separate lecture for this electrolytes alone. We'll be discussing all the things over there, and then I will simply give that important things over there. Okay, so what are the things you'll be come across during treatment of hyponatremia? So seizures will be present. To correction can up to made up to 4 to 5 milliequivalents per internationally first hour. Okay, so if that sodium was seems to be like less than 110, so the neurological symptoms will happens. So 3% will be like neurological symptoms, and then until the sodium reaches 120 level. Okay, so if it reaches the 120 level, right, then there will be a symptom free. Okay, so and then so rate of correction will be like we'll be giving 1.25 milli equivalents. Okay, milliequivalents per hour. Okay, or 8 milliequivalents per international units per day we'll be giving as a dosage. And then in case issues are present, so we'll be going for correction, and then we can be give up to 4 to 5 milliequivalents in the first hour. Okay, and then central pontine myelinosis. Okay, you can get central pontine myelinosis. In case of hypernatremia, we will be seeing that volume status, and then we'll be going for renal and extrarenal, and then that will be leading to diabetes mellitus, diabetes insipidus, and then we'll be seeing that serum osmolality, and the rare of 30% to end up with hyponatremia. So this is the signs and symptoms of hyponatremia, which includes this mnemonics behind this: fried salt, which includes F for flushed skin and fever, and R for restless, and then I for irritable, and then A for anxious, and then they'll be seems to be like confused, and then the blood pressure will be increased, and then they'll be going for fluid retention. The person will be getting edema in the peripheral, as well as the peripheral edema and pitting edema will be there, and then urine output will be decreased. And then if the person is having hypernatremia, they'll be having dry mouth. Okay, so this is, and the salt. What is salt? This is nothing but fried salt. Fried is nothing but, I had explained that what is F or ID, and then you just look at the salt. Salt is nothing but S, which will be the person will be giving skin flushed, and A denotes that the person will be having agitation, and then L denotes that the person will be having low grade fever, and T, the person will be having more number of thirst. These are the signs and symptoms of hyponatremia. And then treatment for hyponatremia: first we have to see the volume status, and then in case of hypovolemia we'll be giving NS2 and D5, and euvolemia will be giving water, and then hypovolemia will be having, we have to look at the salt restriction and loop diuretics with the water. So rate of correction: so in case of acute rate, we can able to give to 1 to 2 milliequivalents per mean international per hour. And then in case of chronic rate, we have to give zero point 0.5 milliequivalents per hour. And then in case of maximum of 8 milliequivalents per international per day. And then during diabetes insipidus also. And then we can say about calcium now. So what is the use of calcium? So calcium, we all know the calcium will be regulated by the PTH and calcitonin, and then the vitamin D plays a vital role in case of absorption of calcium. So and then this calcium also provides a vital role in case of blood coagulation. It is also one of the coagulating factors. So okay, out of the coagulating factor, this calcium provides a vital role over there. Okay, so in that cascade mechanism, and then in this calcium provides a vital role in case of neuromuscular function. And then in ionic, it is about 50%, as in bound form, in the protein bound form it will be like 40%, and then anion bound form, that will be like 10%. So RDA will be about 1 to 2 grams. Okay, so ionic calcium will be about so total calcium plus, this is the thing, zero point 0.8 into 4.5 minus albumin. This is the ionic calculation of ionic calcium. This is a formula. And then relation to acid base balance: whenever that acidosis decreases, protein bound calcium will be I mean, whenever the acidosis decreases, protein bound calcium levels also will be decreases over there. And then we'll be seeing what is hypocalcemia and hypercalcemia. If the calcium level seems to be like decreased, so basically the calcium level will be like 9 to 11 milligrams per deciliter, 9 to 11 milligrams per deciliter. Okay, 9 to 11 milligrams per deciliter. And then in case of hypocalcemia, so post thyroid, and when that hypocalcemia will occur during the post thyroid and neck surgery, and then during any endocrine disorders, during renal failure, during hyperphosphatemia, and during malignant disease, and then during nutritional disorders, and then during blood transfusion, and then inflammatory conditions, you will be getting hypocalcemia. And then hypercalcemia, you can able to see hypercalcemia during endocrine disorders, and then during renal dysfunction, so malignant disease, nutritional disorders, and then granulomatous disease, and then inherited disorders. And then, so what are the symptoms of hypocalcemia, which includes cats? These are mnemonics behind this. Cats is nothing but convulsions, arrhythmias, tetany, strider, and then spasms. Okay, so and then we can able to see the Chostak sign in case of hypocalcemia, and then we can able to see the trouser sign is nothing but carpopedal spasm. And then what is the treatment for hypocalcemia? So 10 ml of 10% calcium gluconate, which is nothing but 1 gram, okay, of calcium infusion is necessary. So at what amount? So with in the necessary for zero point 0.5 to 1.5 milligrams per kg per hour. This is a ratio. So how much they are given? 0.5 to 1.5 milligram per kg per hour. So in this ratio they will be giving the dosage of infusion calcium. So and then gluconate preferred over chloride. And then hyperphosphatemia will be used. And then we have to look into any refractory cases as over there, and any refractory cases is there for the patient, and then we have to think about that. And then oral supplementation with vitamin D. And then we have to look into and then we have to go for tripartite, which is nothing but synthetic PTH. Okay, so hypercalcemia. So hypercalcemia is nothing but what are the symptoms? If the calcium level seems to be like more than the normal levels, like more than the more than like I mean 9 to 11 milligrams per deciliter, right? That will be leading to blood calcium, or seems to be like more than 9 to 11 milligrams per deciliter. So then it will be leading to hypercalcemia, because then okay, I will not enter into the metabolism now. Okay, so the signs and symptoms of hypercalcemia, which includes number one is nothing but bone pain. The persons will be having arrhythmia, and then the persons will be having cardiac arrest, and then they'll be having kidney stones, and then they will be having muscle weakness, and then excessive urination will be there. And then yeah, so it is nothing but bones, stones, and grooves. They will call it as okay. Yeah, and then treatment for hypercalcemia. So maybe the etiology will be like the person will be having parathyroid adenoma. So they should have to stop thiazide diuretics. So the saline diuretics will be given with furosemide. So they have to that will be inhibiting bone reabsorption. And then they'll be going for hemodialysis, and then calcitonin will be given as a short term measure. And then they'll be giving oral phosphates. And then we'll be moving to magnesium. So magnesium levels will be like 1.5 to 2.4 milliequivalents. Okay, so the protein that will be like 30% will be like protein bound form. And then so anion bound will be like 10%, and then free form will be like 60%. So the calcium channel will be the antagonist, and then that will be acting as a cofactor in ATP powered reactions. Okay, and then so this is a physiological test which used to detect that Mg over there, magnesium over there. And then magnesium will be reabsorbed in loop of Henleys and distal convoluted tubular over there. And then the RDA will be about 400 mg. So what is the cause for hypomagnesemia? So the hypomagnesemia has seven important things. So when the person will be having malnutrition symptoms, so malabsorption symptoms will be there. Metabolic acidosis with dialysis and renal failure, that will be linked to alcohol. I mean, if the person is consuming more amount of alcoholism, so loop and diuretics, and the person if the person is having tetany, and then muscular excitability and tremors. And so they'll be having confusion, depression, irritability, and nystagmus. So hypomagnesemia. So the 40% of hypomagnesiemics are hypokalemic. Okay, so it will be like directly proportional, and 60 percentage of hypokalemics or hypomagnesiemic. Okay, so the hypermagnesemia, that will, this is a process behind this. So hypomagnesemia will reduces the ATP production, and then that will be going and inhibiting the sodium, potassium, and ATPase, and then there will be loss of intracellular potassium, and then the loss of potassium in the urine. Okay, so what is the treatment for hypomagnesemia? So 1 gram of magnesium sulfate, which contains zero point 0.1 gram of elemental magnesium, will be given. So up to that 8 to 12 gram of IV over 24 hours, that will be given, like 4 to 6 gram of IV for the next 3 days. Okay, within 24 hours they will be giving 8 to 12 gram of IV for 20. I mean, for 24 hours they will be giving 8 to 12 grams of IV, and then after that they will be giving 4 to 6 gram of IV for the next 3 days. So the dose to be adjusted as per the renal sufficiency. We have to see whether the kidney is functioning normally or not. So and then we have to look into the deep tendon reflexes, and then we have to check that the urine output while giving that magnesium, sorry, magnesium correction. And then hypermagnesemia. So this is uncommon in the absence of renal failure. So IV overdose will be better tolerated, and then the oral overdose. So there will be that neuromuscular blockade will be there, and calcium channel blockade will be over there, and then ECG changes will be there in case of hypermagnesemia. Okay, so the persons will be having the persons will be having vomiting, nausea, muscle weakness will be there, hypotension will be there, bradycardia, and respiratory depression will be there. Okay, so treatment of hypermagnesemia, which includes stopping of magnesium in patients with intact renal function, will be the sufficient one. Sorry, that had been missed out over there. So the calcium to stabilize the heart, and saline diuretics with loop diuretics, and then we can use the dialysis for renal failure patients. This is what this is a we have finished that. We have started with that electrolytes. So electrolyte analysis, we had seen the principle of electrolyte analyzer, and then we had seen that history behind it, and then we had seen the principle, and then we had seen the components, and then we had seen that working or sample processing of this instrument, and then we had seen that what are the components which are being present over there, and then what is the use of the electrode. We had seen the type of electrode. So because the electrode plays a vital role in case of that mechanism. So this electrode has been classified into two: glass electrode and liquid ion change exchanger electrode. So and then what are the clinical applications and advantages of this machine, and then this is a schematic diagram, and then this electrolyte analyzer, and then we had seen the electrolyte imbalance. So in this we had seen hyperkalemia, hypokalemia, so potassium deficit, uh, we had seen that what are the mnemonics for these things, and then in case of potassium we had seen that ECG pattern. This is the most important thing. So during hypokalemia, what happens? So there will be the depressed of ST segment, and then you can able to see the prominent U wave, and then there will be biphasic T wave. In case of hypokalemia, you can able to see the prolonged QRS wave, and then PR interval seems to be long, and then we can able to get tall T waves. This is the most important thing, because they will be more prone to cardiac arrest in case of this. This potassium plays a vital role in cardiac arrest. Okay, so that's why we are just correlating that ECG. And then what is the treatment behind this for hyper and hyperkalemia? And then sodium. Okay, so that's it. And then just remember the mnemonics. Just see that too. Okay.